These are the CT findings, which I find it very useful in this patient. That is not only MRI, but you need to do CT scan because CT scan shows bone better than MRI. And you see how it looks. The peronasal sinus, this is a lesion, pushing the eyeball on the left side. And now these are air bubbles. Observe with me that is the bone, the cortex, the outside cortex looks healthy in a way, while the destruction is from within the inner table. And that goes with the clinical presentation because this cap didn't show any external swelling of the scalp. A part of that heel scar, which is discarging, there was no mass whatsoever. So it seems that the organism had been inoculated inside, and it is working in the dark, and it is only now showing and discarding the grains. Again, another very potent tool. I feel it is very important now in managing such patients, that is the three-dimensional CT scan. You can see the areas of infiltration. And that is how the pathology eroded the roof of the left orbit. And when you look, now we are looking at the left side, so that is the lesion. But look with me on the other side, the heel side. You can see here changes. So in spite of the fact that it is only the left eye which is discarging, but the bone was affected on the other side as well. And that is how CT scan can help us really to diagnose such patient and to plan further management. So this patient was taken to theater, and you see that it's okay. We feel that is we attack our enemy from distance. Again, to respect the higher line, not to disfigure the face. We know that the sinus has already disfigured the face. So that is how we approach by coronal incision. And that is when we open, that the skin is open. And now I am taking the skin down to the area. And now here, that's the bone flap. And now you can see the lesion. And here, you can see how are the grains, the black grains. This is a dura, actually this is a brain. And we could fill up this with Madrella mycetomatous grain. So it had been occupying all accommodated within the cranium. And that is what is left after removal of the grains. That is, we are having the capsule. We are having the capsule of the mycetomas. So that I need to take as well. So, sorry. Oh, sorry. Okay. Sorry for technology. Let me see. So that is, you can see, now I am resecting actually the capsule, and I have to continue with that, and I must tell you, you might not see all here. I have to continue that till the roof of the orbit. As well, I have to go to the other side because I can visualize the area of the operation. So that is being resected, and that at the end of the operation, how it looks. Now look at the bone flap. You can see it from within with the erosions. This is the area what had been really filled by the grains. You can see, and this is the brain now, freed from the capsule, looking forward for it to expand back to its place. And that is a specimen being seen by Professor Hassan. And he's reporting about this neutrophilial lymphocytes, and this is densely sclerotic bone. And again, lymphocytes is monocytes, neutrophilia. This is from the capsule. And this is this chap 10 days later. He just came for follow-up, and now, okay, that scar healed. The proptosis is coming back, and the cervical scar is healed well. So, are there cranial surgical indications, Professor Sheikh? Excuse me. I do respect that we always start with chemotherapy, but I am bringing this topic to this floor because cranial mycetoma is a bit different, because it entails clinical problem that is going to probably lead to morbidity and mortality. So, a scalp mass might be a solitary mass or not verified by just simple investigations, or it might be disfiguring. I don't want to make panic among the audience, but now I feel that is what one should be more careful about scalp masses in general in Sudan. We have to think about that is mycetoma could be the lesion or failure of chemotherapy in cranial mycetoma, or it goes infected, no place, then you have to go surgically to make debridement. Or if there are signs of alarming increase in intracranial pressure, or if there is progressive limb weakness or focal neuric deficit. So there is no question, there is a place to go and try to tackle the problem surgically. However, this without challenges. Challenges to the brain, actually, that is we are seeing a very silent enemy, slowly progressing, and still we are speaking in terms of inefficiency of the chemotherapy, and it has rather aggressive behavior because it spreads itself along the facial planes, and it can destroy a lot before it can present. So as slowly progressive, it is again painless. So it is causing no harm to the patient. How many patients now going around who are having small scalp mycetomas, but they never bothered to come to the doctor? How many of them? Or again, we must remember that we are living in an endemic area. When we speak about chemotherapy, how much is going to cost? Because still now, it is very difficult to provide free treatment for this patient. And we have to think about the side effects of these drugs. Here, when it is aggressive, we have to put in mind this, when we say in the CNS, it is the morbidity it carries. Not only this, it can be fatal. So it can cause equally morbidity and mortality. So in conclusion, ladies and gentlemen, Streptomyces somaliensis remains to be the commonest pathogen in cranial mycetoma. Skull hyperostosis and or lytic lesions are frequent association. Sinus formation is a late event. Multiple cranial nerves involvement is a feature, and widespread of the pathology poses real difficulties in terms of management. This is just an observation. That is, dura seems to confer anatomic barrier. In the few cases, that is the Plitriae and the Maduri, I cannot say exactly where is the source, but early we released a paper on spinal mycetoma at that time, and there were 2 cases of intraspinal mycetoma where the lesion was wholly intraspinal. We haven't seen any external or subcutaneous tissue involvement. It was wholly intraspinal. It proved to be myelorrhea mycetomatous. And lucky enough, Professor Hassan could demonstrate an intravascular grain, and we suggested that it might be this press through vascular. So early surgical intervention lessens morbidity and mortality when we come to the brain. So with that, I might recommend that we must be more critical in evaluating scalp mass generally, because it's very common. There are a number of benign lesions in the scalp which might take it just as easy as that. Since we are living in an endemic area, we should be very cautious, and we should include the differential diagnosis mycetoma of the scalp. And the duration of chemotherapy is to be weighed versus spread of the disease. And again, surgery offers quick decompression of neural structure. Adoption of non-invasive investigations. Now I am very happy, glad to hear that there's a number of things coming out which might help us to detect earlier. And I feel that the early CT scan should be a guide in our approach to such patients. From now onwards, I feel I might be in a position to ask for a CT scan for every scalp mass probably, because we should not miss, and we shouldn't wait till it is that advanced. And again, when we are giving chemotherapy, we must and we must assess if the patient can afford this drug, and we have to monitor our patient for side effects. Surgery definitely is going to establish a definite diagnosis. This specimen being sent will give you, and it is going to shorten the use of chemotherapy. So finally, to say, okay, if we feel that our soil is infested with mycocysts and actinomycetes, again, always we think about farmers that is to be affected, or shepherds. But how about people who are growing us flowers as well? They are using the same land. Thank you.
Thank you, Dr. Muhammad, for this very excellent first-hand work and the very novel approach to these clinical presentations. And so now the floor is open for questions before we go to the recommendations. Yes, please.
Thank you very much. I'd like to go back to the drug management of mycetoma, and I would like to address the issue of expensive drugs in tropical medicine. You see, 20 years ago, Ambisome came on the market for the treatment of leishmaniasis, and it was extremely expensive. But it was the best drug available that was approved very soon, and it was studied very well. It was published and confirmed as an excellent drug. And now, with the help of WHO, the price has come down considerably, and it's now coming within reach of the national control programs. Another example, when I worked in Malawi some time ago, almost every day we saw a case of cryptococcal meningitis, called Cryptococcus neoformans. And there was no treatment available. So the only thing we could do, diagnose the patient and send them home with palliative care, and surely they would die within a week or so. Then, under international pressure, the Pfizer company decided to make fluconazole available free of charge for these patients. And now everybody has access to fluconazole for the treatment of cryptomeningitis. Third example, we all know about the onchocerciasis control program, which was very successful because the Merck company was persuaded to donate ivermectin free of charge. So the point I want to make is, if we think that current medical treatment of mycetoma is unsatisfactory, and we have potential drugs that might be better, but perhaps are now very expensive, the thing to do is first to study them. Make sure we demonstrate that they work, they are better, shorten the treatment, and then go to the WHO, DNDi, UNICEF, whatever, to make our case with the company. Please reduce the price or even donate it free of charge. So the point is really, if we think there are better drugs, the way forward is to study them and come up with evidence. Thank you.
So it means that now we're doing recommendations. So, but okay. Is there anybody taking care of the recommendation here? I think this is a very important junction now. Yes, to take notes of recommendation, please. I guess that recording is going on as well. Yes. Okay. Fine. Okay. So, questions, please.
Hello, Assalamu alaikum. I'm Sani Jobdi from Public Health, University of Medical Sciences and Technology. Following what Prof just said, we already know that mycetoma is endemic in certain countries, of which Sudan is one, and mycetoma is a disease of the poor. I want to ask, has there been any effort to secure some free treatment for mycetoma from the Federal Ministry of Health or from Sudan federal government, since Sudan has to a large extent declared some medical services free? Why not mycetoma, being a debilitating disease at this stage, before getting to maybe advocacy at the international level? If such effort has not been made, I'm suggesting that let's make an effort to advocate for free medical treatment for these poor people who are suffering from this debilitating disease, since the number is few, and I think the federal government can afford. The number of people suffering from the disease is relatively few compared to other more prevalent diseases, and it can be easily taken care of. Thank you.
Thank you very much. I hinted at a recommendation yesterday, which I would like now to put it clear, and this is to the Minister of Health, to make mycetoma a reportable disease, because they only cared for highly infectious disease. So we just want to know, just to say whether it is in the health center in Zalingi, they have seen so many cases of mycetoma. That's enough. I think by the end of the year of this sheet, they have a sheet for the reporting of diseases. We would like to include mycetoma in that one. And this is some kind of a possible survey to tell this. Thank you.
Yes, there is a question in the background there.
I would say that Professor Welsh has used we are people of laboratory. He used a recombinant antigen in his ELISA. My question is that, why didn't you use direct tissue smear for the diagnosis? Because it is acid fast and very quick. Secondly, if you use the recombinant antigen for ELISA, because there is antigenic relationship between other nocardia. And this gives us the idea that there is an expensive kits should be supplied. My question is to all, are we not going to use direct antigens from cultures for mycetoma and actinomycetoma? My second question to Arbab is, did you take history of the cranial lesions, if there is any trauma or so? Or can you say that the primary infection is inside digestive tract or something like that, so that there is metastasis of impuli to the brain? Thank you very much.
Well, regarding the first question, we use the direct examination to identify the organism. If we see that the morphology belongs to an actinomycete, what we can do by this type of technique, that lead us in what type of organisms could we be having at that moment. So if, for example, it's an Ocaria, we cannot distinguish between Ocaria steroides or brasiliensis only by direct examination, but we can culture it. That test that Dr. Salinas did was only for Nocardia brasiliensis. It cross-reacts with 8 to 10% with Actinomadure madure, but the grains of Actinomadura madure are completely different than the grains of Nocaria brasiliensis. Regarding the why we use the ELISA, well, sometimes you don't identify it. We have had some rare cases in which we don't find the granule. So in those cases, has more value the use of ELISA, because in Mexico the more frequently found organism is Nocaria brasiliensis. Of course, our results, for example, regarding what Dr. Pajal was saying, is true. We cannot say what is going to be the response of all the other organisms with the treatment that we were given in Mexico, because there are different organisms. So the experience should be the Sudan's experience and given to the rest of the world in those cases, and explore another possibilities. Our experience, I repeat, was based in patients that most of them are included among Nocaria brasiliensis, a few Nocaria Actinomadure madure, and one Streptomyces somaliensis.
So the last one will be Dr. Arbapi will respond to the questions, and after that, with your permission, we are going just to receive recommendation. Okay?
Well, I just mentioned about there's a number of these patients who did not report history of previous trauma. But we must take that with caution, because if I am seeing patients with history more than 10 years, how many of us recall what happened to him 10 years back? So one must be very cautious about saying there is no history of trauma. But what draws attention here, when I see that there is no subcutaneous lesion, because with thorn break or whatever trauma it is, one would expect that to see a subcutaneous granuloma and then later on involving the other tissues. But when I see only intracranially, then only then I feel that the source of the inflicting organism must be something else other than direct inoculation.
Is it the recommendation or a question?
It could be a question and recommendation as well.
Okay, go ahead.
All right, thank you. I'm Mr. Abdulaziz Abdelmunaim, vascular surgeon, Soba, Khartoum University. My question for all experts in mycetoma surgery: do you use a special theater for mycetoma surgery, or you use the common theater as well? If you use a common theater, tell us what precaution you do. Thank you.
We have a ready response here.
I remember when I was in Saudi Arabia, we opened the clinic in King Abdulaziz Hospital. And our enemies were the surgeons. He said, if we get this, they will infect our other patients. And this is not true. This is untoward fear. Mycetoma, like any other, I suppose you are keen in your theater on aseptic techniques. And that's what they do. And we do not have yet infection person to person. there is always this circle that goes through the soil, we think, and then it comes back. Because sometimes or in all cases, you have infections of the foot. There are no kissing infections on the other foot. Are there? No. So I would like to allay the fears of our fellow surgeons. I know that they gave Ahmed a headache on this. You don't need a special theater for this. I'm sure he takes precautions to clean his theater before he goes out. Yeah. And the usual household cleaning is enough. Thank you. Yes, yes. And they have to go through that cycle. They have to go through the soil and then come back to us.
Just to respond to my colleague Abdulaziz, that out of the 5,600 patients with mycetoma, we encounter none of them have surgical contamination from the theater or other equipment or instrument. And still, Professor Sheikh is seeing patients for the last 50 years, and he has no infection with mycetoma. And he has a problem with some of the flash went to his eyes, and still has no mycetoma infection. And last week, I had a patient with mycetoma, and have a surgical excision for that patient, and I allow my colleague Dr. Abdulaziz to operate on my aunt with a very tedious surgical procedure, that is a bypass procedure in the lower limb. And thanks God, she has no problem with the mycetoma infection.
I do also infection control. I'm the director of infection control at our institution, so we deal with these issues. And I mean, we have fungi that are more likely to be problematic, like Aspergillus and others, and still we get them into regular, even positive pressure theaters, and there has been no problems. And it's not recommended that we put them in a special theater. So I don't think we need special precautions there.
Okay, please go on.
One comment, that even in experimental animals, it was impossible to inoculate the organism and to introduce the infection animals unless you put actual grains in this experimental animal with Windy in Rotterdam, and nothing happened until we use the mycelia, and after we use an adjuvant, and after that we were able to have this granuloma formation at this site. As you mentioned, that probably there is intermediate host in the cycle of this infection. We don't know what is this host. If you can know the host, you can have a prevention measurement adopted for these patients. This is very important. Thank you very much.
Okay. If you allow me just to say, for the sake of the surgeons who are worried, for the sake of the patients, can we establish a standard operational procedure? I think if we can put such a recommendation, we put a standard operational procedure for cleaning the rooms after making a surgical operation with mycetoma.
Which is universal, I think. Yeah, it's universal.
We can have such a recommendation. Recommendation? Okay.
Maybe we modify this to have a standard approach to operating.
All right. Yes, okay.
Asia Said, I'm a veterinarian. Yesterday, Dr. Abdali gave very excellent and convenient presentation about treatment of mycetoma. My question is, why do you exclude the local treatment with the systemic treatment? And you didn't mention the anti-inflammatory or anti-inflammatory drugs to be used.
Thank you. Topical treatment. I guess because it didn't work. I mean, early on with the topical imidazoles used
and even some other types of treatment didn't work, and for obvious reason, because it was deep enough and it was not reaching. Could it be, like adjuvant therapy, something with the tea tree oil? It seems to work in vitro very well. Maybe for some superficial, maybe kind of a horizontal type of spread of the lesion, maybe. But I think we need definitely systemic therapy. I'll answer afterwards the other one.
In 1970, we performed some studies. We have several patients with mycetoma caused by Nocardia brasiliensis. We prepared dimethyl sulfoxide together with trimethoprim sulfamethoxazole, and we applied topically. After about 3 months of treatment, all the lesions disappeared, but bone involvement didn't have any response. So we didn't we never reported that findings, but so it's necessary to give a systemic treatment. But we did local treatment with dimethyl sulfoxide in those days.
Thanks a lot.
Answering the other anti-inflammatory, it's so interesting because today when we have a visit to see some patients, it was raised actually, would anti-inflammatory drugs help, like steroids? And it hasn't been tried in mycetoma, but we have tried steroids in some other forms of granulomatous fungal infection like basidiobulomycosis. We have used it in about 7-8 patients. Excellent results. We've given it tapering over 6 weeks, and it did shrink the lesions and allowed for better response. Would it be the same for mycetoma, especially mycetoma? I don't know. The pathology seems to be different than basidiobulomycosis. But I think maybe it's worth it in a trial on few patients, see if you get any response. Because if you give steroids for a short period of time, you really don't have immunosuppression. You have mainly anti-inflammatory effect. So it may be useful. I really cannot say. We have to try it and see.
I would like to have a recommendation to the WHO. The one I gave before was to the federal minister. Now we would like WHO to put mycetoma on the list, at least of the neglected diseases.
Thanks a lot. My second question.
Another one?
Excuse me, yes.
So please, fast.
Okay, to Professor Godfellow. But before my question, I have a small comment about mycetoma infection in animals. I have documented data about black-green mycetoma in horses and eumycotic mycetoma in dogs and eumycotic mycetoma in cows, and infection, subcutaneous infection of subcutaneous nodules in cats, when the isolated microorganism was Nocardia, I think, Nocardia africana. The same microorganism which have been isolated from human, which is the main causative agent for pulmonary nocardiosis. My question for you, is it the time to consider that mycetoma is a zoonotic disease? And thank you. Yes.
I don't know is the answer. It's very interesting that you've isolated Nocardia africana from cats. Was this from a cat? Was this from a cat suffering from nocardiosis or mycetoma?
It's considered as feline mycetoma, according to the recommended data, documented recommended data.
Right. Well, I mean, I think that's a very interesting result because it suggests that it might also infect humans as well.
Okay. Thanks a lot.
Recommendations, please. Really, we are running short of time. Recommendation. Well-structured recommendation.
Maybe a recommendation.
Go forward.
Susan Ibrahim Abdurrahim, PhD student in Sudan University, Faculty of Medical Laboratory Technology. I ask Mr. Mahjoub, do you think the strategy of treatment started with isolation and identification of the microorganism instead of random trials of drugs. And so we prevent the patient from the side effects of the treatment.
I think both Professor Welsh and myself, we said the various investigations we do for before starting the treatment, and amongst those was the isolation of the organism, and if we can, we will do the in vitro sensitivity. But believe me, it's not as easy as the bacterial, the antibacterial microgram. But we have that in mind. Recommendation?
I hope my recommendations were taken, but I just want to emphasize two recommendations. One of them that is for all clinicians, when they are faced with scalp swelling, to consider mycetoma as a differential diagnosis, and they must, even in the absence of sinuses, so you should not wait for sinuses. The second thing is the adoption of CT scanning in any patient who is having head mycetoma.
And I have a recommendation which seems to be simple. I hope for all doctors, they try to diagnose their patients and see whether they are actinomycetoma or eumycetoma. Whether they want to do a surgical approach, want to medical approach, this is very important. For the surgery, the eumycetoma has got this fine capsule. They can go around it and interfere. And it's very clear when you feel around the actinomycetoma, it's a very ill-defined margin. So even starting clinically, radiologically, laboratory facilities, it is easy and it is very important to distinguish between these two categories before you have any sort of remedial approach. Thank you. Ahmed?
So many hands. So I'll suggest.
Thank you. I would like to emphasize that before recommending the federal government or the WHO, that to emphasize or to pay attention, to teach our medical students, we as teachers, about mycetoma and how to differentiate between different types, being in the graduate or in the postgraduate students.
Curricula of medical schools.
Education of people so that they will come before it was very severe illness. Thank you.
I think of a campaign of awareness post this conference, post-conference awareness, some sort of media coverage. I think that is very badly needed, really. When I come to this conference, I met a lot of people. Some of them were educated people, and they asked me where I'm going, and I said for mycetoma conference, and they are wondering what is mycetoma is all about. I think we need to make a lot of awareness programs regarding this campaign. Okay.
Okay. Because the role of animal in transmission of mycetoma is not yet studied, so I suggest or I recommend it to do a serodiagnosis, not only for people in contact with animals, but also in animals in contact with human. Thank you.
I have suggestions related to what has been discussed yesterday about the prevention. I think establishing a registry, a well-formed registry is very important. And I think with a well-designed case definition and all of that, I think and probably WHO can help kind of engulfing mycetoma within their programs, like the diarrheal, the malaria, the others. So the funding or money issue maybe can be covered through other kind of outsourcing in a way. Right. I think. Okay, so I guess that will be very useful. Second, I think the Andalus project